Welcome, everyone, to our next edition of our Pediatric Hospital Medicine Podcast Series. I am your host, Dr. Tony Tarchichi. Just to give you guys an update on where we are, this is our 11th podcast in our Pediatric Hospital Medicine Series. I'm going to do our disclaimer, and then we're going to get right into it. This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Now, just to remind you all, we're coming to you from Children's Hospital of Pittsburgh, or UPMC. I am a MedPeds trained pediatric hospitalist here at Children's Hospital of Pittsburgh in the Paul C. Gaffney Diagnostic Referral Service. That's our pediatric hospitalist service. Today is our special holiday edition of our podcast. We're not going to do anything festive, but we're going to talk about something seasonal, which is the flu. Today we're going to discuss our flu vaccine. How good or bad is it, or okay is it? And we're going to get into a little bit of this Tamiflu debate. Now, to do this, I'm honored to have my special guest with me, with Dr. John Williams. Now, Dr. Williams is a professor of pediatrics and chief of the Division of Infectious Diseases here at Children's Hospital of Pittsburgh of UPMC. The major focus of his research is the immunity and pathogenesis of the human metapneumovirus, a paramyxovirus discovered in 2001. He did receive the 2007 Pediatric Infectious Disease Society Young Investigators Award, and in 2014 was awarded the E. Mead Johnson Award for Pediatric Research, the most prestigious research award in academic pediatrics. He's the author of over 120 peer-reviewed research publications, has extensive experience with other academic activities, including NIH study sections, national and international academic societies, member of the editorial board for the Journal of Virology, Journal of Infectious Disease, and Journal of Pediatric Infectious Disease Society. And he received the Vanderbilt Academy for Excellence in Teaching Award and has served on the PIDS Fellowship Awards Committee, chaired it in 2016, and the Society for Pediatric Research Mentoring Committee. So, Dr. Williams, thank you very much for being here.
Tony, a pleasure to be here. Thanks for that very kind introduction.
So first thing, let's get our disclosures out of the way. I have nothing to disclose.
So I serve on a scientific advisory board for a company called Quidel that makes diagnostic tests for infectious diseases such as Group A strep, influenza, RSV, and other infections. And I serve on a data safety monitoring committee for GlaxoSmithKline for respiratory syncytial virus vaccines. I don't have any kind of compensation or support from manufacturers of anti-influenza medications.
So, John, why don't we start with why we're here? Let's start with how is our flu vaccine this year in terms of efficacy, in terms of the flu strains we're seeing, and what quality are we seeing?
So this year, we're in good fortune that it's actually doing very well so far. And just, one other background fact to mention to people, everybody is aware of sort of how common influenza is, especially in children. About 20% of U.S. kids get the flu every year, and 5 to 10% of adults. But flu is in the top 10 leading causes of death every year in this country. Far more people die of flu than are murdered every year in the United States. So, the most effective prevention of flu is the vaccine, even though, as you know, in some years it's a very good effective match and others not so good. And that's because basically the WHO and other policy bodies have to make an educated guess 6 months in advance of the flu season of what do we think next winter's flu is going to be. And so far this year, it looks like they guessed right. Flu is starting to take off in the country. There are widespread activity in a lot of states, especially in the South. It's mostly H3N2 type influenza, and of those, 98% that have been tested are a good match for the vaccine. So it looks like the vaccine will be a good match this year.
Now, I didn't know the numbers were that high in terms of flu mortality. Is that higher in children, or that's children as well? It's usually the top 10 causes of death for kids.
It's top 10 causes of death overall in U.S. citizens. The deaths from influenza and pneumonia, which are grouped together, range from 30 to 60,000 in a given year. For pediatrics, there are several hundred reported cases of pediatric deaths of influenza every year. I've personally cared for, unfortunately, many children who died of influenza. So the real number is probably more than that several hundred that's reported. And this is where the flu vaccine is so important. Of children that die of influenza, about 2/3 are unvaccinated, and more than half are otherwise healthy kids, because we're pretty good at getting flu vaccine to our high-risk children. Pediatricians and parents think about this. So the child with asthma, the child with cystic fibrosis, the premature infant, we think, oh, we need to make sure that they and their family members get a flu vaccine. But it's so common that with otherwise healthy children, people think, well, it's just the flu. If Joey gets the flu, he'll be okay. And those deaths, they're tragic, and they're only the tip of the iceberg for the burden of flu disease, but many of those deaths are preventable with flu vaccine.
So now this contrasts what we see with the respiratory syncytial virus, RSV, where the morbidity there really is in congenital heart disease patients, congenital lung patients, those who have issues. And healthy kids do just fine, whereas the flu really is hitting healthy kids because we seem to really vaccinate those who have congenital issues.
That's true in terms of the most severe outcome of a fatal outcome. For RSV, the problem there is, of course, we don't have yet a licensed vaccine for RSV. But if you look at young children who are hospitalized with RSV under 2 years of age, 3/4 of them are otherwise healthy. So there is an enormous burden of RSV disease in otherwise healthy children. But you're exactly right, Tony, that the risk of hospitalization is much higher in the high-risk kids. And overall, there are more hospitalizations from RSV in the U.S. every year, but fewer deaths. So worldwide, several 100,000 kids die of RSV every year. But in the United States, not many kids die of RSV every year because we have, pretty good advanced medical care for those children.
All right, so John, we're going to transition to a topic that's been a hot topic for hospitalists now for a while. On our listserv, we see a lot of conversation about whether Oseltamivir, trade name Tamiflu, is a good idea or a bad idea. There was the Cochrane review, then there was the new data that came out from the drug companies, and then the re-review. And there's just so much discussion about whether or not we should use it. Is the CDC right in making their recommendations? So could you take us through kind of the history of this debate, how we got to where we are now?
Yeah, I'll be happy to, Tony. And I think it is a great question, clinically, and it brings in aspects of policy and economics. And I'll just disclose, so I've been studying respiratory viruses for almost 2 decades and practicing pediatric infectious diseases for almost that long. And I think that many children, we should consider treatment with influenza drugs. So just to disclose that I don't know if I call it a bias, but after years of experience and knowing the literature well, I come down on the side of that we should consider treatment probably more than we do. So, the history is complicated by a few things. Number one, most of the data, the vast majority of the data is in adults and not in children, as is true for many, many drugs. And the early trials that were done to license Oseltamivir and the other influenza drug, Zanamivir, which later we should touch on both of those, these were done in mostly healthy adults, and they were done using criteria of influenza-like illness. So the adults weren't tested to prove they had influenza. As we all know, many other viruses cause illnesses that look like flu, and of course they're not going to respond to an influenza drug. So those studies did show some benefit, but this was part of the later Cochrane review, and this is where the economics comes into it. The early Cochrane reviews found benefit in use of Oseltamivir. However, those early reviews used only the published data. And later, the authors of those reviews, Tom Jefferson being the senior author on most of these, went back and got unpublished data from Roche. And when you included this unpublished data from those early trials, the evidence for benefit was much weaker. So this brings into questions of, industry bias and how much is this driven by profit and questions like that, which I think are very important and relevant questions for those of us in academics and thinking about drug companies. Just to put that into context, we spend over $1 billion a year in this country on Viagra alone, and we spend only about $1 million on Tamiflu. So it's not really much profit for the drug industry. However, so many subsequent studies have been done, either a few randomized control trials or a number of observational studies. Most of these suggest benefit, but all of them suffer from common problems, which is very heterogeneous patient populations between otherwise healthy adults and elderly, frail adults or patients with underlying conditions. And not all studies use a rigorous definition of flu, which is a lab test to prove that it's the flu. And so these are the things that have really limited our interpretation of the data, which is there benefit or not? And then the final piece of those studies is, what's the outcome measure? So the easiest outcome measure would be death. I just told you, like, a lot of people die of flu every year, but 20% of American kids get the flu every year. Most of them aren't dying. So should the outcome measure be hospitalization or secondary pneumonia or otitis media? These gradations of illness, not simply a yes, no, flu or not, but how severe is it? Those are not well studied in any of these. And that's really what we care about. We know that these drugs are not going to magically shut down the illness immediately. We want to prevent, severe outcomes and shorten illness. So that's why the literature has been difficult. There have been several meta-analyses, and we can talk about these, where they basically, and the audience is probably familiar with meta-analyses, the authors do a systematic review of high-quality published studies that are free of bias, and they pool all that data together to sort of make a synthetic, very large study. And the pretty consistent findings from those is that Oseltamivir shortens illness by about a day. And that's, I think, the one consistent finding that we can say is almost certainly been confirmed by all these studies.
And one of the studies we're going to discuss, I'll bring up now, is published in the Clinical Infectious Disease Journal. The authors are Ryan Malosh, Emily Martin. This is a good time to bring up my disclaimer of, if I butcher people's names, which I'm likely to do, I apologize. I just don't know how to pronounce your name. It isn't purposeful. Along that line, the next author is Turho Heikkinen, W. Abdullah Brooks, Richard J. Whitley, and Arnold Monto. The paper is Efficacy and Safety of Oseltamivir in Children, a systematic review of individual patient data, and meta-analysis of randomized controlled trials. This just came out. This is only an e-print. So what they did was they looked and did a meta-analysis of all the potential randomized controlled trials. What I liked is they separated out patients who are intent to treat and intent to treat infected. And intent to treat infected in this population was a diagnosis of flu by some sort of study, by some sort of test. And then intent to treat is those who had flu-like symptoms. But what they did was they conducted a systematic review to identify randomized controlled trials of Oseltamivir in kids. They obtained individual patient data and examined protocol-defined outcomes. Then they conducted a two-stage random effects meta-analysis to determine the efficacy of treatment in reducing the duration of illness, estimating that using differences in restricted mean survival time by treatment group, and then they examined complications and safety. They also looked at they used a Cochrane protocol to look at the quality of each trial to evaluate the risk of bias, and their primary endpoint for the meta-analysis was duration of illness in hours, and they followed the study-specific endpoints. Resolution of illness was described as one of the following conditions must be met for at least 24 hours. The child was afebrile, cough or rhinitis were either absent or mild. The child had returned to normal activities. So, and one of the things that this trial found and other trials have found is Oseltamivir use in asthmatic kids. They have not found that it works. Can you talk about that? And I feel like that's overall. Do you agree with that?
I think there's a lot weaker evidence in asthmatic kids, and part of that is, again, back to the numbers. So in most of these trials, the numbers of children with asthma were fairly small. I think, as you just highlighted, Tony, a strength of this meta-analysis, some meta-analyses just take the published studies and they pull the data directly out of the published study. Another way to do it, and what these investigators did, is the individual patient-level data, where you contact the authors of the original study and say, hey, will you share your database with me in a protected fashion so I don't have any patient identifiers? So then, when the authors of the meta-analysis pool the data, they're pooling the original raw data, and that makes it much stronger. So, right, this is one of the huge challenges, is that intuitively, we know that children with asthma are at somewhat higher risk, and intuitively one would think if you treat them, that will be good. But most of the trials just don't have enough subjects with asthma. And again, as pediatricians, when we say asthma, there's a big difference between one of my kids who used to wheeze every year or so when he got sick when he was young, and the child who's on inhaled corticosteroids every day and using a rescue inhaler twice a week. That is a child who's probably at very high risk from the flu, whereas my once-a-year wheezer, probably not at increased risk.
Now, some of the safety issues with oseltamivir, with the side effects, we should discuss those a little. In just about every review I've found, the risk of nausea and vomiting is higher in children. In children who seem well or who not classically defined as the flu, it seems they have a higher risk, a side effect of headache. And then, of course, the psychiatric and renal effects. Do you want to talk about that for a little bit?
Yeah, it's a great question because I think with any drug, we're always weighing risk and benefit. And both the data support the nausea, vomiting, and anecdotally, I've personally seen that. My wife, Stacy, is a general pediatrician. She sees it a lot. So I think you do weigh the risk and benefit there. One point to make here, and this gets back to both the way we approach medicine in this country, we like pills, we like oral medicine, and marketing. Roche has marketed oseltamivir, Tamiflu, very, very well. So there are two approved antivirals that have similar mechanism of action. Oseltamivir, a pill or liquid taken orally, and Relenza, zanamivir, which is inhaled. So zanamivir is only approved for children 7 and older because they have to do this dry powder inhaler and take a deep breath and hold it. But there's basically no nausea, vomiting with that. And people always forget about zanamivir, both out of pocket or on our insurance, we have the UPMC health plan. It's like $60 to $80 out of pocket for either one. The cost is generally similar, but when people are weighing risk and benefit and the nausea, vomiting, which is the sort of common and significant side effect of Tamiflu, I think people forget that for older children, there's another option that has basically no increased risk of nausea, vomiting.
Now, zanamivir, has the data shown its effectiveness equal to oseltamivir or Tamiflu in terms of what we've seen with these reviews?
Yeah, in short, yes, although the studies are smaller for zanamivir because it's been less well marketed and less widely used. But the data that exist show that zanamivir is just as effective. It was used in an IV form during the pandemic and showed effectiveness there. The major limitation of zanamivir is because it's an inhaled medication, it's not recommended for people with lung disease, like the kids with asthma that we were just talking about.
Can we talk a little about some of the more significant side effects that Cochrane Review brought up, the acute the kidney injury, and of course the psychiatric side effects for Tamiflu?
Yeah, these are great questions. I'll take the psychiatric first because I think that a very strong association was shown primarily in Japanese populations. That could be confounded by 3 things. One, influenza itself can cause CNS symptoms or inflammation. There's never been any evidence of influenza in the brain or in the spinal fluid. My group and a number of other groups have done PCR on spinal fluid. So in children with what we call influenza encephalopathy, we think it's immune mediated. You don't find virus there. So that's one point that could confound this. Another is that these epidemiologic reports that show an association are mainly out of Japan, which has, interestingly, the highest per capita use of oseltamivir in the whole world. They also have the lowest rate of flu mortality in the whole world. And people have argued, that, maybe those two are linked. I mean, that, very difficult to try and actually study or prove that. But you're seeing a country where the drug is used very, very frequently. So does that mean it's a true association? That has not been replicated in other populations with near the same strength. And then, we're all familiar with the genetic predisposition to Kawasaki disease that's much, much stronger in specifically Japanese populations, not any Asian, but specifically Japanese. So, could that be playing a role too? So, I think it's definitely something for people to weigh in the risk-benefit analysis. And I think, certainly the way we think about, for some vaccines, if children have a history of seizures or neurologic disease, that's something to weigh when we consider giving certain vaccines. I look at this the same way. If you have a child with known serious psychiatric disease or conditions, or if they're on psychoactive medications, that's something to definitely consider in the risk-benefit ratio.
So then my follow-up question to that is, as we're seeing the rate of psychiatric illnesses in pediatrics going up, if we have a hospitalized patient who has a history of depression, maybe even suicidal ideation or attempted suicide, and or other psychiatric illness, who is admitted with the flu and may or may not have gotten the vaccine, how do we weigh the risk-benefit ratio? Is it, if they're severely ill in the ICU, just give it to them and deal with the consequences later? If they're just on the floor, a little hypoxia, see what happens? How do we go about this?
Well, I mean, now you're really into the art of medicine, and I wish your listeners could see me start waving my hands at this point. These are difficult questions, Tony, and I think, but you're touching on the factors that you would weigh as, what is the underlying risk of the patient? What is the severity of illness and the likelihood that they will progress to become more ill? And one thing that we haven't touched on much yet, but it's a key limitation in these antivirals, is how long have they been sick? So the original studies, and most studies since, show that if treatment is started within the first 48 hours, it's significantly more effective than if it's after 48 hours. And the reason for this is basically influenza and many viral infections. What causes disease is one part the virus and one part your immune response. And so if the virus is already going away on day 3 or 4, and now most of your symptoms are from your immune response, an antiviral is not going to help because the immune response is already started. And I think the strongest evidence for timing effect of these drugs is when they're used for prophylaxis. When these drugs, Tamiflu or Oseltamivir, when they're used for prophylaxis of high-risk contacts, they're extremely effective. Like in a nursing home, one adult gets the flu and they quickly prophylax all the other residents. It's extremely effective because it's on board before they get exposed to the virus. So I think the timing is really a key thing to weigh. If I saw that hypothetical patient you mentioned, 14-year-old, they have underlying disease, cystic fibrosis, say, so I'm worried about them, they're high risk, but they also have significant psychiatric disease, and they've been sick for 4 days, and they just now got sick enough to come in. I really feel like in that patient, at 4 days, there's probably so little benefit of the drug, and I do have some concern in that setting about potential psychiatric side effects. I think that would be one where I might say, I'm not going to do it in this case.
I'm glad you brought up prophylaxis. For our listeners, the other article I've reviewed for this is in the British Medical Journal in 2014, published on April 9th, 2014. The authors are Tom Jefferson, who's the reviewer, and then Mark Jones, the senior research fellow. There's Peter Doshi, Elizabeth Spencer, Igho Monapayo, and Carl Hennigan. Now, this is called Oseltamivir for Influenza in Adults and Children, Systematic Review of Clinical Study Reports and Summary of Regulatory Comments. Now, both this article and the one we brought up earlier said the same exact thing, which was prophylaxis using Oseltamivir in high-risk contacts. The drug seems extremely helpful for those populations. And so the evidence seems to point that direction. Where it doesn't point is if you have influenza causing pneumonia doesn't seem to affect. Influenza triggering otitis media, this recent paper I brought up in the November of this year seems to say it helps, others say no. But they all seem to say the same thing, which is it may shorten duration of illness by about a day. It helps prophylactically for high-risk contacts. And for the hospitalized patient, we talked about the timing of it, less than 48 hours being beneficial. Can we talk about the CDC recommendations? The CDC recommendations seem somewhat broad. Anyone moderately ill, which to me, when I have residents, the argument is if they're admitted to the hospital, they're probably at least moderately ill. If they were mildly ill, they'd be home. And on the adult side, and the evidence for the adult side is stronger in terms of hospitalized patients. It really does help. There isn't the same level of evidence on the pediatric side. Would you say that the CDC recommendations are stretched out to say if a kid's in the hospital admitted with influenza, we should be putting them on Oseltamivir?
Well, right. So this is the difficulty of recommendations like that, where they're trying to sort of give people simple guidelines to go by. And that is what the recommendations say, is that for high-risk individuals, which is adults over 65, children under 2, or with high-risk conditions, or all hospitalized patients with influenza, if within the first 48 hours, they should be treated with a neuraminidase inhibitor, with Oseltamivir or Zanamivir. And I think if they are treated early, I think those are good guidelines. The CDC guidelines also say, they make it a little more vague to give people a little wiggle room, but they say something like can be considered for otherwise healthy patients if within the first 48 hours. I think a lot of it comes back to both the timing. If you're just now getting into day 3, 72 hours, if it's a high-risk patient who's hospitalized, I would still sort of think about it. If you're into day 4 and 5, I really think for most patients there's no utility there of an antiviral, except the group of immunocompromised patients. And now we're back into the art of medicine, and the CDC kind of can't capture this, but patients who are immune compromised, stem cell transplant, solid organ transplant, chemotherapy, immunomodulatory drugs. I mean, this is a growing population, even in pediatrics. They can shed virus for days or weeks. In fact, a colleague in Canada reported a young girl with ALL who shed influenza virus for a year. The same exact strain of virus. She just kept shedding it. She never cleared it. So in an immunocompromised patient, if they show up day 4 or 5 of illness and they test positive for influenza, I would still strongly consider using these drugs only in that population because we know that they're likely to have ongoing viral replication.
Interesting. And we can stretch that out for us to our genetic population, kids with SCIDs or severe combined immunodeficiency or others. Now, can we discuss the FDA comments on Oseltamivir versus the CDC? The FDA is a little more guarded in terms of how they view Oseltamivir. So the FDA basically says that Tamiflu or oseltamivir phosphate has been approved for treating type A and B influenza. However, the majority of patients included in the studies were infected with type A, which is the most common in the U.S. Its efficacy in the treatment of influenza in patients with chronic cardiac disease or chronic respiratory disease hasn't been established. It's approved for the prevention of influenza in adults and children aged 1 year and older. An efficacy of Tamiflu for the prevention of influenza has not been established in immunocompromised patients. And then in italics, it talks about adverse reactions or quality problems experienced with the use of this product may be reported to FDA's MedWatch adverse event reporting programs at the bottom of the page. So it's a little more, I think it's more what we've been discussing, which is we think it works. We don't have a ton of data on it. And immunocompromised, we're not sure. It's a little more guarded than I believe the CDC is. Would you agree?
I would agree. I think the FDA is always a little more cautious. They have a different regulatory sort of responsibility to, follow laws and regulations to make sure that drugs are approved and safe, because the FDA approval, that means, people can use medications and treatments without as much concern of getting sued for bad outcomes. And if the FDA approves tests or treatments or devices, then they can bill for them to get reimbursed. So their approval carries a lot of implications beyond the CDC guidelines, which, it's sort of like the difference between laws and custom. In the hospital, we have bylaws and policies that are strict and written down. And then we have a culture that isn't written down. We're collegial. We're good to people. We like kids. I don't think you find any children's hospital with the bylaw and policy that says, by the way, we like kids. So I think that's why there's some difference here. But they're both getting at these same issues of, weighing risk-benefit, considering I think a key thing is how long has the patient been ill? Because it's very clear, and again, this is true of many respiratory viral infections, certainly true of respiratory syncytial virus and metapneumovirus as well, that, virus peaks in the first few days and starts declining, and the illness lasts beyond that. And so, starting an antiviral 5-6 days into illness is probably not going to be very effective. Unlike a bacterial pneumonia where the bacteria are continuing to grow, and at day 5 or 6 of a bacterial pneumonia, we don't say, well, house is already on fire, we're not going to do anything. No, we would start an antibiotic and start reducing the bacterial growth. But that's because the germs have very different sort of kinetics. In a viral infection, in an acute viral infection, virus comes up, peaks on day 3 to 5, and then goes away within about a week or so. And many of the symptoms are caused by the immune response. In a bacterial infection, bacteria are continuing to grow often throughout the infection until either it's treated or the patient dies, or many bacterial infections will self-resolve. But that's why we don't really talk about late treatment for bacterial infections the same way as we do late treatment for an acute viral infection.
So if we wanted to solve this problem we have with Oseltamivir, or that some people have, or that we're having in the discussion on our listserv and in the literature, what do we need? What type of studies do we need, and do we know if people are doing them?
Yeah, so there's a few things that we need, some of which are coming. So one thing that's really critical is accurate diagnosis. A huge problem is that if you don't have a test for influenza, that statistically that patient with a quote-unquote flu-like illness probably doesn't have influenza. I mean, right now in Pittsburgh, we have a lot of influenza, which is mostly H3. We also have a lot of RSV, metapneumovirus, and parainfluenza viruses 1 and 2. So when you and I see a sick child right now today, we may as well toss a coin to determine if they have flu or not. So we need rapid diagnostic tests, and in hospitals, we generally have these more available. In smaller hospitals, they may not be, and in many physicians' offices, they either don't have any rapid diagnostic test, or they have the rapid antigen test, which is pretty good in young children, but not great. So that's a critical tool to be able to use these drugs wisely. The other thing that we need, which is much harder, is better studies. But it's very difficult, to do really the ideal study. We want to know, okay, we don't want to just prevent death. Of course we want to prevent death, but we want to prevent bacterial secondary pneumonia, hospitalization, all these things. So to do the ideal study, you need a lot of kids, and you need to follow them prospectively to look for all these outcomes. And you have to include kids with various compromising conditions. And you really need to do it in different centers because the flu is different in different places in terms of timing and prevalence. And so this ends up being a very large, expensive, multi-center study. And drug companies have no need to pay for that or no interest in paying for that because the drug's already approved. So I understand. I'm not judging the company in that sense. Why would they pay for it to get an additional indication for immunocompromised patients when there aren't that many of those? And the NIH and the CDC do fund lots and lots of important clinical research, but I don't think they're going to fund a study like this. And so, we end up sort of cobbling together observational data and retrospective studies and, meta-analyses like this. And Oseltamivir recently, within the last year, the first generic version is approved. So now there's really no incentive for Roche to do further trials of it. So I really think, unfortunately, the data we have are going to be the data we have, and it's unlikely somebody's going to do a large multi-center trial to really answer the questions that you're raising. And so I think we're back to, as we're used to being in pediatrics, using the data we have, an art of medicine, and saying, what is the net benefit for this patient if I use this drug?
So then I think to summarize what we know is the data looks like Oseltamivir will shorten the duration of illness of flu-like symptoms by roughly a day. We know the data doesn't point to it being effective as of yet in asthmatic patients or preventing secondary bacterial infection. We don't have the great data to say that definitively, but what we have now doesn't look like it. The side effects, the most common are nausea and vomiting. In healthy kids, they've seen headache. And then, of course, there's the renal side effects and the psychiatric side effects, which we've talked about. And the decision to use it should be based on a number of factors, such as how long they've had the illness, 48 hours or more, 48 hours or less, their immunocompromised status, other diagnoses they have. Chronic cardiac patients are cystic fibrosis patients, which we may be a little more cautious in. So basically doctoring is the answer. Is we have to look at the patient, decide with the risk-benefit, and take a stab at it and see if we're right. And if we're stuck, of course, we can consult our ID colleagues if we're at a facility that has ID, but most places at least have a phone consult which they can come up with. And the sad part is it doesn't look like we're getting much more data, much more good randomized controlled trials, which I didn't expect. So is there anything I missed there?
Well, just a couple of things. One is that you had asked me before, and I realize now when you say it, I didn't mention the potential for renal toxicity, that's been mainly seen in hospitalized patients. And these are patients, the patients in the hospital that we use anti-influenza drugs for are often very sick patients. They're in the ICU. They're often getting other nephrotoxic medications. And adults, of course, have higher rates of renal toxicity in general. So people have tried to adjust for that in studies, but I would say the evidence, is not very clear. I do think it's fair to say in otherwise healthy children, there's essentially no significant risk of nephrotoxicity, certainly no more than ibuprofen, which we use like water in children with fever. And I think another just sort of editorial observation, it's just interesting to me. So I've been studying respiratory virus for, 20 years and longer than that, really, taking care of kids with respiratory viral infections. You think about the way that we use antibiotics, often inappropriately, but for, colds and quote-unquote sinusitis in a 1-year-old and bronchitis. And, people use antibiotics widely and often inappropriately with little reservation, although we're getting better. Okay, so we finally get some drugs for flu that are reasonable, and there's this unbelievable sort of resistance and backlash. And it's a little mysterious to me as both a pediatrician and an ID doc. I mean, we spend fabulous amounts of money on chemotherapy buying a 68-year-old male another month of life, when that same amount of money would treat 50 of the flu kids that we just talked about. So, it's a little mysterious to me that this area, from the social standpoint, I don't mean the medical things that you and I just talked about, but from the social standpoint, there's kind of a big focus on this, like, we need to save money and not treat kids with the flu. I can think of some 90-year-olds with cancer that we could maybe not treat and save a little more money. But that's just my own editorializing.
And I will say the group we're talking to now, the hospitalists, are known at this point for their QI research and their antibiotic stewardship. So they would probably say we're trying to cut down everything. And if we can cut down that, cut down Oseltamivir. But I think what we would love is clear ideas on who it helps and who it doesn't help. It doesn't seem like we're getting that at all anytime soon.
I don't think we're getting clearer ideas. I really think the data favor its use in most, if not almost all, hospitalized children. If they're severe enough to be hospitalized, then they have severe disease. It's enough to bring them in the hospital. If they're within the first couple of days, and if there's no significant contraindication. Because if we, let's just say we take the data at its concrete, face value, which it's only really powered to look at duration of illness. Okay, if it shortened it by, the number we're getting is about a day. If that kid goes home a day earlier, for the cost of the Oseltamivir, right, the system has saved money. Now, if we prevented complications, that would save money, but we don't know that it does. I would like to think it does. My personal belief is that it probably does, but we don't have evidence to guide us, and that's what we should use when we have it. So I think I can't, in good faith, argue we should be treating all these kids with anti-influenza drugs to prevent complications, because I don't have any good evidence to show you that it works for that. One other point for us to remember when we're talking about influenza treatment, and for all of us as pediatricians and physicians to share with our patients and families, the flu vaccine is not perfect, but it's the most effective prevention we have. And if we can encourage all of our otherwise healthy children and their families to get it, the absolute best way to protect those high-risk kids is for their whole family to get vaccinated. And there was a beautiful study, multi-center study, that came out a couple of years ago now in adults. I've said for many years that the flu vaccine doesn't always work great, but something is better than nothing. So there was a really nice study, a multi-center study of about 8,000 adults nationwide in a CDC flu surveillance network that found that overall the flu vaccine attenuated disease. So usually when we talk about effectiveness, we're saying, did the flu vaccine prevent you from getting clinical flu? This study looked at, did having had the flu vaccine, lessen your severity of illness? In other words, if you were hospitalized, were you less likely to go to the ICU? Were you less likely to die? Were you less likely, even if you got sick, to be hospitalized versus the emergency department? And the answer from this huge study was yes, that having flu vaccine on board, even if it doesn't prevent illness, ameliorates illness. It lessens the severity. So I think a lot of people say, well, the effectiveness is only 60%. Why should we do it? That other 40% of people who still got flu are probably still better off for having had the vaccine.
I think that's a great point, and that's one of the points that was always driven home to me in residency by my mentors like Barry Deshefsky and others, that it really does attenuate when you get the flu. Now, for those of you listening, this is a controversial topic, especially in hospital medicine, so I'm sure there are going to be people disagree. I always put my email at the end of my podcast. I'll say it now. Feel free to email me with any discussions, comments, compliments, or any issues at all to Tony, TONY.Tarchichi, TARCHICHI, at chp.edu. That's at chp.edu. So I'm going to take this time to wrap up. I sincerely want to thank my guest, Dr. John Williams, for joining us on the podcast today. I really appreciate your time.
Tony, it's a pleasure. Everybody get a flu shot, wash your hands, and have a happy holiday.
And I'm going to echo that, the wash your hands part too, but definitely happy holidays to everybody. I believe last night was the last night of Hanukkah, and I think we're in Kwanzaa, and then, of course, Christmas is coming. So happy holidays to everyone. Happy New Year to all of you. I hope you have a very safe and happy New Year, and I won't see you till 2018 when our next podcast will start up. A few acknowledgments. Of course, I want to acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. The University of Pittsburgh for giving the free CME credit, and there will be CME credit attached to this podcast. Feel free to please follow the link and answer a few questions we'll come up with, and you'll be able to get your free CME credit. And then to the Diagnostic Referral Group for allowing me to continue to do this podcast month in and month out. And to all of you who are listening, thank you very much for listening to the podcast. Again, this is not a subscription podcast. We don't have any advertisements because of the CME portion. It's all free. So thank you very much for listening. We really appreciate it. Hope you had a great 2017. I hope you have a wonderful 2018. And we will see you next time. Thank you.